and it is my honor to introduce Mary Crutchfield. Um, she is a psychiatric nurse practitioner as well as a family nurse practitioner. She works at her practice, Leva Psychiatry, in Virginia Beach, Virginia. She specializes in eating disorders and supports individuals and their families through the process of healing and recovery. She focuses on education and helping break the stigmas associated with eating disorders and mental health. And so with this, we're going to make this conversational. Thank you so much, Mary, for joining us and for giving us your precious time and your knowledge on this very, very popular topic, as it turns out. We had so many that had registered. But I sort of want to start with your topic, because you could have talked about anything within mental health, and why the topic of diet cultures and talking about toxic bad diets, eating disorders. Can you tell us a little bit about where that came from?
Yeah, so first, thanks, Courtney, and everybody at NAMI for setting it up. I appreciate the opportunity. I'm glad so many people are coming, so it makes it worth it too. So I picked the topic because I started out as a family nurse practitioner working in a very specialized sickle cell clinic and didn't really see any of this in any of my education, and then went on to graduate with my Psych NP, and I had the opportunity to work at a partial hospitalization program in Richmond. And for about 2.5 years, it opened this whole world of understanding that I had no personal experience, or at least didn't think I did have any personal experience, kind of like a lot of people, like, I don't know what you're talking about. I don't have disordered eating. I don't have an eating disorder. And then I realized, as I've been treating patients over the last year or two, that if I spend more time with people, with any of the clients that I see, or if we're digging really deep with some of the students that I've had, we realize that the whole diet culture, or the culture in general around food and weight, is tremendously more impactful than I think any of us realize, like, as providers. And I know there's a lot of providers attending, but then for the people who aren't, it's things that are just around us all the time that we don't even fathom until we learn a little bit more about it. So I picked the topic because I felt like I'm not at all the most certified, most credentialed person to talk about it, but at the same time, I'm at the level where I know that I know enough to share what was helpful for me as a provider for people that need to hear it, whether it's a provider or just people that wanted to tune in and figure out what it was.
Do you think that it's probably heightened the topic, or maybe it had always been there before the whole social media bend, and now it's just more of a dialogue, and it's more pervasive in the conversation in terms of the eating disorder piece? Or it definitely has been there, but is it always been there at that same level?
Well, I mean, I think that it got worse. A lot of things got more prevalent during COVID with our youth, because I haven't seen the level of what we're seeing right now. So I've had a lot of people come in and have their kids do binge eating challenges because of TikTok, or they're stuck at home and they're kind of thinking about these things more. They're hearing conversations in the family, around family members more, around weight and food, and oh, I gained weight during COVID. Oh, I didn't gain weight during COVID. But it started, I would say the prevalence of it's been around forever, but the war on obesity with the whole model of dietitians, the American Dietetic Association, the American Medical Association, like all of and the government, trying to give nutritional education to people and trying to say that being obese means you're unhealthy, kind of triggered things to heighten. And then now we're in COVID, it's getting even more prevalent.
Okay. So that sort of brings into, I would like you to talk a little bit about diet culture, because before that term, as well as some other terms we're going to hit on, I wouldn't be able to verbalize what that meant. I would be giving my own very uneducated opinion. So
I want to hear what that is.
Right. Nothing that's going to be good. So talk to us about diet culture.
Sure. So diet culture we're all a part of it. And so when I get into talking about, eating disorder or disordered eating, we can sometimes get a little defensive because it's something that we're all a part of. So I had the luxury of growing up in Africa and the Philippines. And so I wasn't exposed to it until I was in my 20s when I came back to the US at 20, 21. So the culture, I would say, I'm going to refer to it as in like what we're around in America, because I don't know outside of that, so when I talk about it, I'm talking about here, but we're all a part of it. I said earlier, it kind of started around when when the whole war on obesity was started, and it's the conversations that we have about the thin ideal, which I'll clarify in a second, and then being fat phobic. So the thin ideal is everybody, we need to shrink ourselves. We need to be smaller, thinner, fitter, healthier, clean eaters. We need to do as much as we can to look a certain way. And that way is typically, thin, right? So that's the thin ideal. That's a huge part of what a lot of the language around diet culture is. And then fat phobia being, if you are obese or overweight, then you are lazy, unhealthy, you're going to die young, you're probably unhappy. And it's all the concepts around, we're afraid of gaining weight, or we talk about gaining weight. So some practical examples would be, you see your girlfriend and you're like, oh, you look so beautiful, you lost weight. Or even as small as your kid saying to you, hey, do I look fat? And our response is, no, you don't look fat, you're beautiful. Instead of, what do you mean you're fat? What does that mean? Other things like dinner table. Oh, I ate so much food for for Christmas or Thanksgiving. So, I'm going to scale back after this, and I'm going to start my diet. I'm going to do my New Year's resolution. I'm going to eat better after this. Those are a few examples.
Those are some really good examples, and some very, very good examples in the impact of diet culture, the thin ideal, the fat phobia. What is give us some of the impact of what you see, and maybe let's even tie that in obviously we're NAMI, the mental health space, tie that in to what that looks like today.
Well, I'll speak from a provider standpoint, what I see as a provider, and then I'll speak from a personal standpoint, because it's kind of,
that's a good idea.
Interesting to be in the two different roles. As a provider, I see a lot of things that start to root people into shame and a feeling of needing to control. So it's this whole concept that we're not good enough the way we are, or if we had our baby and now our body's changed, we need to change our body, or, we're not going to be as desirable to other people. So it's a lot of, negative body self-image. And then, that kind of can stem into more disordered extremes that have diagnoses like body dysmorphia. As a whole, for the youth, I know that the young adults are struggling now already with disconnection and isolation. So we have, all the young people like feeling like, okay, I can only have friends that have the same problem, or we can restrict together, or I can only do certain things in front of those people. So it's a lot of disconnection, and I think we all know that if we, we want to heal, we want to recover from anything, like we have to have people. I mean, we just have to have support. That's what I see as a provider as some of the bigger things, leading to eating disorders. So, the extreme of it, where it's functionally limiting you, whether you're getting physically ill as a result of it, and you're having to, get medical attention. Sometimes medical attention, nobody picks up on it for a really long time, and on a personal level, I would say it's really uncomfortable, like if we're hanging out with our friends and our conversations are about how much weight we gained or lost, or what we're going to do to change the way we look, we're basically, taking all of our creative energy of positive things we could talk about and focusing on the thin ideal, like this ideology that it would be better to shrink ourselves. And it just sounds so bizarre.
Yeah, and that's perpetrated all over through any kind of media outlet and any kind of association, and it's never under just that the health piece of it. It's always about the weight as opposed to like eating. You mentioned clean eating. You mentioned different things that are you can find them anywhere, right? Of what people are doing, the different diets that people are trying, but it is it's hard to not have that in your face as opposed to
Right.
living a healthy, happy, productive lifestyle. Um, and
Well, I wanted to say something too about, because I wasn't going to go too in depth about it, but some of the diets like, the clean eating or keto or intermittent fasting, I can't tell you how many people who aren't even my clients that are seeing me for disordered eating or eating disorders, they're coming in to talk to me about depression or ADHD or anxiety. But I hear that conversation, like, let's say out of 15 people a day, I might hear it like 5 times. Like, oh, I'm on a keto diet, I'm on an intermittent fasting diet. And the interesting part is that, the weight loss companies do these 2-year studies, to promote weight loss and say intermittent fasting works, keto diet works for losing weight. But they're normally short-term studies. And in the long run, we know that people gain back the weight plus 10%. So if the goal is weight loss, we're failing anyway. And the goal shouldn't be weight loss, but it is. And even when there's a part of it, there's a lot of failure of that whole medical system because it's so focused on, like the medical weight loss clinics. How are we going to help you lose weight? How are we going to give you enough medication to lose weight? How are we going to do things to help promote the thin ideal?
mhm,
And then meanwhile, exacerbating the people who struggle with any form of restriction, even if it's mental restriction, like you're eating enough food, but mentally you're like, well, I can't have that, but I can have this, and I can't have that, but I can have, like carbs are bad or dessert is bad, but I can eat all these vegetables. It just promotes more of that, more restriction.
as opposed, right, absolutely. Um, Before we get into some of the things that you do to address some of this, when a patient comes to you, an individual on there, can you define for us just an eating disorder versus disorganized eating? And I know they're both unto themselves. So let's start with disordered eating.
Sure. I actually wrote a list of, I think, some of the most common things that I hear. And I'll share those because I want to say that the majority of us do it. Like, I have to even admit that, I'm talking about this stuff, but I've had these conversations with my friends. And then as I've learned more about this world of how to heal and process some of the stuff, I've realized, oh my gosh, I've done some of these things. So disordered eating is at the level where we're influenced by our culture, we're influenced by social media, by the language, by our nutrition programs in 6th grade, where we're told to count our calories and do a dietary recall, all of the weight loss clinic, our families. So these are the ones that I would say I hear most commonly, and I'll run down the list. So the first one is cutting out food groups that are not clean, considered unhealthy or bad. So I said this one earlier, like carb elimination diets. These foods are good. Labeling foods as good, labeling other foods as bad. Second thing, skipping meals. So if we eat one meal and then turn around, we can't eat the next meal. Or there's even a new one, it's an eating disorder not specified, but people who drink alcohol for their calories and then they don't eat as much food because they got their calories in their alcohol. So kind of like that, skipping one thing so you can have another. People who go on multiple fad diets. So, if I sit down, and this is a part of my assessment, depending on what someone comes in for, I actually ask them how many diets you've tried. And a lot of times people are pretty proud to tell me how many, when really, on my end, I'm like, I don't, like, it's not good. The longer the list goes, the more concerned I am. But they'll be like Atkins, and then I did South Beach, and then I did Weight Watchers, and then I did, and it's this long list of different diets, which causes weight cycling. So weight going up, then weight dropping, it goes back up. The next one is a lot of rigid rules around exercise. So kind of going back to that whole US Preventative Task Force, says if you do 10,000 steps a day, that's healthy. So then we have people, tracking it constantly on their phones, on their watches. And it's like, okay, well, if I didn't get my 10,000 steps, then I didn't do good today. I failed, or I didn't do my 30 minutes every single day. And so, I'm not going to rest. And so that is considered like a mental restriction. There is food rictuals, which kind of goes back to what I said earlier, but people make certain food rituals. Let's say, for example, you were raised, like I kind of heard this when I was younger, but like you should drink skim milk, not whole milk.
Oh yeah.
Or you should eat, low sugar this or low fat this, or, just drink black coffee. So certain things that you do, that you have all these rules in your head that you don't even realize are rules. This is the culture, right? Somebody actually messaged a question about supplements, like, are dietary supplements something that are encouraged, or is this kind of a part of disordered eating? I would say just in general, when we're supplementing foods with something that's not really a food, it's a processed, weight loss, sort of like if you drink a Slim Fast, then you don't have to eat, and then you have a calorie deficit, that's going to be more disordered,
So the thing, take the apple cider gummies that are all over, and do that, because then you won't be it will suppress your appetite.
Right. And like the Garcinia Cambogia, I think that was the name of it. I mean, like, you name it, they've thought of it, from, like different medications, but specifically about the food piece, that's a part of it. And then, some of the things that go into that mentality of, all the food rules and rituals, as we get into, obsessing about the body weight. So just constantly weighing ourselves and looking at this number, which is pretty arbitrary. It's not, our BMI is not actually linked to like longevity of life or health. There's so many other factors that are more important than the number of weight. But we've been taught that weight is a marker that we have to ask. So, because we've got to give it to insurance, so that they, like they ask with every patient, what's the patient's weight? And so, sometimes we look at the scale and we say, oh, well, I gained a couple pounds, so I'm not going to eat, or I'm going to eat less, or I need to like go on a diet again. So that would be more disordered eating.
Right. Well, right before this call, and a few of us were talking, and I said something that I lost a pound or two, and I put on jeans, but they're still a little tight. And I was like, I got a couple more to go. Like my whole motivation was so I can fit into my clothes, because I'm too cheap to buy new clothes, which probably is a little bit of a problem unto itself. But that it factors into our conversation so many different ways about how we, our physical presence.
Right. I mean, a lot of us keep our old clothes that don't fit anymore, thinking, oh, we're gonna try to fit back in those one day. And so we torture ourselves by having them in the closet, because we're like, okay, well, we're definitely gonna make that a goal, instead of that day saying, I'm gonna wear something that feels good on my body.
Absolutely. Or maybe what I did when I lost a little weight, I got rid of all the bigger clothes, because I was like, because I know you won't buy, I don't want to go out and buy new clothes, right? So there was again, on the being thrifty, there was that
right.
point. How do you know when, or how does one know when someone has an eating disorder versus disorganized eating?
So that's a good question, because when we look at trying to figure out when is it actually a problem, and a lot of people ask in many different ways, like, how do I know it's serious? How do I know someone needs to get help, or that it's significant enough? And when I say we all do these things, how do I know that, this isn't something that's really a problem for me that I need to take more seriously than just like, oh, okay, maybe it's okay to eat dessert more often, like give myself permission. So eating disorders are going to be diagnosed by mental health professionals, and they have to meet the criteria. But generally speaking, when we're looking at all of the disordered eating behaviors, which I only listed a few, right? I think I went over like 10, but if you're doing multiple, if you're participating in multiple behaviors for the disordered eating, plus you start to have impairment in your life because of it, then that's when it really starts to constitute an actual disorder. So you have, level of function starts to decline. So this is what I see on my end. I have a lot of people coming in saying, my child needs an ADHD medicine. And they do their psychological testing, and yep, sure enough, they pop positive for inattentiveness, right? Or people come in and they're tired and they're very depressed and they just can't seem to focus and they don't want to get out of bed. And it's super easy to miss for a psychiatric provider to miss unless you're asking all of these questions. So, when you're digging deeper, it's like, well, you're skipping meals. You've been doing this for years. You have pretty compulsive exercise. You're exercising. You don't give yourself a break. Eventually you start to see a decline. And a lot of times the way that I am able to determine this is based on my assessments, but you can see it through people's behavior. I mean, you will eventually lose your ability to focus and pay attention if you are participating in so many of these disordered eating behaviors. You won't be going out with friends and eating with them. You won't be doing all of the things you would typically do, either because of shame and disconnection or because you just feel so terrible eventually, so it all depends on the level of functional impairment in addition to like how time consuming all of this is. So one person may have a couple food rules that they've done their whole life that they learned from their parent or their family or just social media. And then other people will have it deeply ingrained where they don't, they're participating in these things all day long. Like I'll talk to people who will think 3 days ahead of time about what meal they're going to order when they're out with their friends, because that's how consumed they are with how food impacts their body.
Oh, wow. Do you find that there's often on there, I mean, and this might be a very ridiculous question, that they are supplementing the food or something else that might be wrong or that's missing, that becomes like their go-to for their comfort or their confidence? Or is it not, that would not be the case at all?
So I'd like to say that the brain, the way that the brain, if we take all the labels away, like what's disordered, what's eating disorder, what's addiction, what's depression, and we're not trying to label something for purposes of labeling it, but we're looking at, we're looking at the actual, like what's going on inside of the person. We can see that, I'll draw it manually in the air.
Okay.
We can see that people's anxiety rises, right? And so as anxiety rises, we try to find ways to manage it. And in psychiatry and therapy and mental health, we're trying to help people figure out how they're going to manage their anxiety in a healthy way. But let's say all is some of these disordered patterns, right? I'm going to manage the fact that I feel overweight and I can't fit in my pants. So I'm going to just not eat for the day, or I'm going to do less eating, or I'm going to eat because I'm emotional about it. That is when you start clamping down on a compulsion. So the behaviors that we use, if they're coping skills that aren't working, your anxiety is going to temporarily go down. You get a little bit of a reward. I'm in control. I made a decision. I've decided that I'm, going to do these behaviors, healthy or not. But then of course it's going to loop, and your anxiety is going to start rising again. And we keep going through that loop. It's almost like an OCD loop, but that's not a true diagnosis of it, Yeah. But it's that cycle that we get into. So to answer your question, and some people asked about that too, is there a link between OCD and eating disorders? Yes. Trauma and eating disorders? Yes. There's a huge connection between addiction and eating disorders as well.
Interesting. All right. What about some common myths of eating disorders?
Well, I think, and I almost feel like I talked a lot about, the restrictive rules, but we also have, not just, it makes it sound like most people are restricting, or that they're going to look sickly. But, you know, the number, like one of the biggest myths that I struggle every day having these conversations with people and trying to say, this is bigger than you think, your food is your medicine, is that we think that people with eating disorders, that you're going to be able to see it, and you can't. You know, a lot of people are in a, you know, a range of their, you know, BMI, which I'm saying is not an important number, but, you know, if I'm screening them for the insurance purposes, they're normal, you know, considered normal weight, normal BMI, but they've done excessive like amount of restricting over time, or they may have gained weight and then gone down to this weight and we're not picking up on it. And so I think one of the common myths is that, you know, you're going to be able to tell, and you can't. You just can't tell unless you ask all of these questions, you know, very detailed questions about food rules, food behaviors, how you were raised. Another one is that weight determines whether you have an eating disorder or not. Unfortunately, the insurances kind of dictate a lot of treatments. So let's say I send somebody like in their normal BMI to get help. The dietitian services are typically not going to be covered. They're not going to be able to go to a higher level of care for help because they don't meet all of the criteria showing that, you know, they have that they're an abnormal weight or they're a weight outside of that range. So, you know, you can see where people get lost in the cracks all the time. When I have these conversations, well, I'm a normal weight. Well, I'm in the normal BMI. Well, my pediatrician said I was fine and all my labs looked good. And they have for a very long time. So tell me why I can't focus and pay attention then. I'm like, well, if we're eating kale and we're getting in, you know, massive amounts of volume, but nothing of substance, eventually your body's going to tell you, I can't do this anymore.
And everything won't look so good. And right. We've got the time to work on it now. You know, we've got that. That is interesting because if you're talking about the cycle of up and down that a lot of individuals will go, a loop, if you will, on there, then your weight will sort of manage itself on there. So it wouldn't meet criteria for you to be diagnosed and then treated because you're not 75 pounds dripping wet, you know?
Right. And that's largely, I think, what people attribute it to is, oh, well, I'm eating food and I'm not underweight or I'm not overweight.
So treatments, we have, they come and you are able, they're willing participant in getting their eating disorder treated. Want to talk about what those treatments look like, and then I want to find out about some of the recovery possibilities and what you've seen, and you just share a success or two.
Absolutely, yeah. So treatments, multiple people asked about resources, you know, where can we find resources for people? So I wanted to make sure that I address what I tell patients kind of almost in the same model. Like we are obligated to tell people what their options are, whether they decide to do any of them or not. So here's all your options. You can do one, you can do none of them, but at least know what they are. So, you know, the first level of care is considered outpatient, which is, you know, what I do. So you see your outpatient provider. We like when it's disordered eating or eating disorders to have a treatment team, because it really does take more than just your psychiatric provider to treat, you know, to treat a person or a client with struggling with some of this stuff. So you have a psychiatric provider on the treatment team. You want your primary care doctor, and sometimes they're familiar with eating disorders. In my experience, a lot of them don't really have to screen or have the time to screen for it, but at least if you're aware of what's going on, you can collaborate with them. So a psychiatric provider, a primary care doctor, a registered dietitian that is certified to treat eating disorders, and a therapist. Now, so
there is a specific certification for dietitians.
There is. So it's it makes it a little bit hard to find resources because of that. But through the International Association of Eating Disorder Professional Foundation, IAEDP for short, there's a lot of extensive training. And that's why I said I don't even have all the credentials, but this is where the majority of therapists and registered dietitians will go for their additional training to get their certification.
And we will, just so everyone knows, Mary's provided a really a great list of resources that we're going to show at the end of this presentation and will be available for you to reference. That's one of them, I believe.
Yeah. So because it's got a search tool where you can figure that out, and actually too for providers for continuing education. Oh, so, okay. We're outpatient, and this is what I try to explain to people is you're at the very, the bottom level of the stair step. If you want to think of it as stairs, we're at the bottom level where you're seeing everybody maybe once a week at the most, maybe twice a week at the most, and your psychiatric provider once a month, your primary care doctor once a month for labs and things like that. So it's very infrequent care, but it's just enough to start kind of processing the anxiety. If there's trauma, you're kind of delving in, but you're stable and you're medically stable. So none of your medical risks are going to end in hospitalization. And then, a lot of this is dictated by insurance. So the second stair step is intensive outpatient programs. We've heard of those when it comes to addiction treatment, but they actually do exist for eating disorders. And typically insurance says, okay, we'll pay for 3 to 5 days a week, 3 hours at night, or 3 hours in the morning every day. So you're getting 3 hours of support daily, which you can see is a lot more support than like once a week for an hour with a therapist. You're getting a lot more involvement. Then the next level up is going to be partial hospitalization. That's considered a complete day of treatment. So prior to COVID, you would go into centers for that care, so you were there for 8 hours a day, and then you'd go home and you would try to, do at least one meal at home by yourself with some support of your family. But then you have dietitian, you have internal medicine, you have the psychiatrist involvement, you have so much support in a PHP program, and it's not a locked hospital unit. It's not what a lot of people are afraid of when I say, hey, I think we need to consider a higher level of care. They're actually very nice centers. And then the next step up would be residential, in terms of if you're stable, you can stay in a residential place for a while if you're stable, if you're medically stable, and you get 24-hour treatment or supervision. And then, the highest level of care is going to be if you're sick and you need an intervention that really, you're medically compromised, you're going to need to go inpatient, like to an actual medical unit for some medical monitoring. Okay. So there are treatment facilities all over the US. And at the end in the resource packet, I put a website where you can actually search, and it'll tell you by zip code and what insurances are covered for each treatment center.
And that'll be really helpful. So you have had for this on the recovery front, what are these level of successes that you've experienced with your patients that you've seen?
So there's a huge controversy. There's a lot of people that are naysayers, about different things like eating disorders and addiction, that say, okay, recovery is not possible. You're going to struggle with this forever. You're not going to find, peace. You're going to have body image issues for life. I can say that the people that I have had go to treatment centers, they have the greatest success of recovery, and recovery is definitely possible. So we're talking about freedom from the diet culture mentality. We're talking about the fear of gaining weight not being the overriding variable in their mental health, being able to, go eat out with friends, shop without being triggered. We're talking full recovery. It's actually pretty amazing. I've had quite a few people come out of treatment centers that dedicated to them, went through each stair step all the way down back to outpatient, and the majority of their symptoms that were originally diagnosed as ADHD and depression are gone.
Mm-hmm. Well, I hear you on this, and this might be a whisper controversial. I also know that we see in medicine that if you have someone who's living a healthy lifestyle, meaning getting the good nutrition, right? Getting some form of exercise, a good fitness, whatever that looks like, that a lot of the medical issues, not the the mental health can be alleviated as well, but on the medical side can disappear, like you just said, would happen on the flip
Yeah, I
side.
think the biggest thing, the biggest resistance that we have in the beginning is when people come in for care, the conversation that we have to have is, weight loss is not the goal,
Right.
right? And weight gain may be the goal medically for some people to help give the brain enough healthy fats to work and to protect all the organs. But outside of that, we're looking at symptom management. We're not looking at like weight, the number, actually knowing this number equals they're healthy. We're looking at people improving over time. So it definitely is a difficult conversation to have people come in and say, I know you want to lose weight. You're coming in, I want to lose weight or I want to gain weight, but we're actually going to put you through a healing process. And it's not going to be focused on getting you to that number that you had in your head.
Right.
It's going to be kind of uncovering all of this.
Yeah, you said you can't see it. And there are people that are at we could walk around and say they're at a normal weight, right? And they could have the worst nutritional plan because maybe of them, and a lot, maybe that is how they were raised, but maybe it has to do with some disorganized eating piece but they're not healthy on there because of what they are eating. And it is not about, that they are carrying too many pounds. So,
well, the interesting thing is that, there was a lot of literature back with the war on obesity trying to say we're going to help support people lose weight because of comorbidities like diabetes, hypertension, so we're going to focus on this BMI. There's been plenty of literature since then showing how unhelpful that is and how, being healthy doesn't have much to do with the weight itself. It has to do with living a life where we're doing things that make us feel physically vital.
yeah.
And when I'm seeing patients, I think somebody asked, what do we recommend for, diet and exercise? The answer is we don't, we don't recommend diet and exercise. Like moving forward, now that you're listening, we recommend body movement. That's how we refer to it.
Okay.
Do you enjoy jumping on a trampoline? Do you like ballet? Like, what do you like to do that lights up your brain and keeps you physically healthy, but is enjoyable, and so it's not that, okay, you can just, there's kind of like this counter argument of, well, if we just kind of allow people to eat whatever they want to eat, they're going to be unhealthy. I mean, that typically doesn't happen when people are healing, when we're actually uncovering some of the food rules and the restrictions that we've put on ourselves. So yeah, we don't tell people to diet and exercise. We start mindfully eating and we encourage body movement.
So definitely the wordsmithing does make a huge difference there because of what those others the connotation might be when you say, eat, have a really nutritious meal, that could translate in a negative fashion as opposed to, we're going to really work on being mindful about your choices that you're making.
Right. And figuring out like, are we sitting down and eating really fast? We're all stressed out. We're all working ourselves to death in America. We're constantly working, we're eating on the go, we have a food availability issues. So, when I was in Tanzania, everybody thought it was great if you were fat. And so every time I would come back from boarding school, it would be, oh my gosh, you're so fat. And, like that seemed normal at the time. I mean, at the same time, I was like, Mom, is that normal? Because funny enough, my mom's a dietitian. And she was working with women to try to show them how to eat healthy in a culture where they didn't have food availability, so they're like, don't have access to a lot of protein and things like that. So it's just funny because I'm like, Mom, is this normal? Everybody's telling me I'm fat. She's like, yeah, you look great. You look great. And then you come back here and I'm like, oh, this is not, I can't look like this. I'm supposed to look a certain way. Like if you're going to be acceptable to society or you're going to have people view you as somebody that's healthy, you're going to look like this. That's an ideal.
Right. Well, you come back here and then you would see in the States, someone would be like, ooh, you've had some fun, you've had some fun at school.
Right.
Sure, yeah. So, oh, I got that. Medication.
Yeah. So a lot of people ask, like, what about medications with this disorder? And it ties back into your question earlier about like comorbidities, other mental health things that might kind of be stemming from or contributing to the chicken before the egg, with this. So there's medications that have shown to help for people that have more obsessive and intrusive thoughts about food, about, what they need, about anxiety. So there are medications that help with that. I wanted to specifically address Vyvanse because it's indicated for binge eating disorder and it was FDA approved for that. So medications are definitely not the top priority in eating disorders. I want to say, and for Vyvanse, I really shy away from Vyvanse for binge eating disorders specifically because I originally, before I knew what I know now, was like, oh, sure, let's give an appetite suppressant and let's decrease binge eating episodes, because that's what the insurance wants to know, is that you're having less than 3 binge eating episodes a week. And then, we're better. But the truth is, if we as psychiatric providers just prescribe Vyvanse and we don't have the dietitian who knows what's going on asking the questions, well, does that mean you're restricting all day and eating at night? Well, does that mean that you decided that you're not going to have breakfast? Or does that mean that, if we're not dealing with the underlying anxiety of what we're trying to manage or control, whether it's trauma, whether it's stress, body image issues, then we really are doing a disservice to the people that we're seeing as our clients by just saying, take this and I hope it works. It works. It'll stop you from eating. In general, it'll suppress your appetite. And we've known that for years with all the ADHD meds, but it definitely doesn't solve the problem. For the other eating disorders, like people who avoid food, there's a certain eating disorder where you just, the kids, I see it a lot more in kids, but they kind of just avoid eating. They have a very narrow, picky window of food that they'll eat, and it gets narrower and narrower and narrower till we're down to just like grilled chicken nuggets, and that's it. And that's all we're going to eat. They're more avoidant of food groups and more restrictive in different food types on their plate. You can give medication to help with the intensity of how anxious they are, but again, it doesn't help with any of the things that we're combating, except let's just like lower the volume on what's going on in their minds. So the medicines are helpful, and most people that go to treatment will be on medication for assistance. I will say that I haven't had too many people go to treatment that don't come back to me on medication, but that's not our go-to.
But would you say that's sort of a standard, the standard op if they do go into a partial hospitalization or into a residential program?
Normally, like when I said if you get diagnosed with an eating disorder, it's like all consuming. If you're going to a treatment center, it's made you medically unstable enough to where you have changes in your vital signs. So your heart rate either drops or goes high. You can have numbness and tingling in your fingers and your feet. You can get dizzy when you stand up. Your hair can thin. Your cholesterol actually spikes when you restrict. So a lot of people come and say, oh, I have high cholesterol, but I'm really healthy. So if you start having changes in your lab work and your vital signs, then you kind of constitute, hey, you need a higher level of care. Most likely they're going to say, hey, this anxiety, these intrusive thoughts are significant enough to where you need to be put on some medication for help.
Okay. There's a lot of people on it, and I know the question came up, how do you have a loved one that has an eating disorder? What is your role in supporting them? What does that look like?
I have to say that was the toughest question that came up. I said earlier, eating disorders, addiction go hand in hand. Eating disorder, trauma goes hand in hand. We have to think about eating disorders as a mental illness. It's not about food, it's not about weight, and it's not a choice. So that lack of insight there into what's going on isn't something that, you know, people have a whole lot of control over. This is not a willpower issue or a moral failing. So the last thing any of us want to do is control somebody. I mean, maybe we want to, but we shouldn't, right? Like maybe we want to get them help and force them into help, but we can't. I will say, from a standpoint of what I have found to be the most beneficial, is to take a step back from control, whether you're a friend or a family member, and to be as vulnerable as possible with the person you're concerned about. Because it's so, like eating disorders and addiction and trauma, there's so much shame. There's so much shame surrounding it, and so much stigma, and so much misunderstanding, that if you say the wrong thing, or if you support in a way that's like, you just need to eat more, you just need to get more food in, if you could just do that, things would get better. It's so much deeper than that. So it takes a very, like, a high level of vulnerability to be able to sit down and just say, I love you and I'm concerned, and I'll do what I can to help, because that's really all we can do. That's on the level of conversation, but on a very practical level, finding the right people to be in the treatment team is the hardest part of getting treatment, because the resources are so rare and the people certified are so few and far between. If you send somebody to a regular registered dietitian that focuses on the obesity model, and you tell your friend, hey, I'm going to set you up with a dietitian, and that's what they go see, like, that's it. You know, we've just made the situation worse. So I would say being an advocate and trying to navigate who understands how to treat this disorder is probably going to be the most helpful thing that like a family member or friend can do.
How have you found, I mean, obviously you and I have had a lot of conversations about serious mental illness like schizophrenia and other pieces. And sometimes that individual does not have the insight about their illness. So it's much harder to connect at the onset. For an eating disorder, how willing do you find your patients, how willing do you find them to be really participatory in the program, if you will, like in the
Well,
strategies?
it kind of comes back to that, you know, recovery phase, you know, system of trying to figure out where people are in their recovery. So, you know, just very briefly, if people aren't even contemplating that they have a problem, which happens a lot, people come in, this is my problem, is this. And I'm like, you know, well, okay. They're in the pre-contemplation phase. They haven't even thought this is a problem, versus someone who's like, I think I might have an eating disorder. What are my options? I want to explore. You know, versus I'm really sick and my family isn't going to help me anymore unless I get help. And you know, I can't do anything. I've lost everything. I can't focus in school. I can't make friends. You know, it depends on where people are in their phases of recovery. I would say it's typically a really horrible discussion the first time.
Yeah.
The first time I sit down with somebody, it's because it takes being vulnerable. It takes being vulnerable. I can't rush an appointment from somebody who's barely understood the concept and say, this is actually pretty serious, and I really care, and I really want to explore the options with you. You know, and there's a lot of resistance typically. And at the same time, you can't dance around the topic, you know, and that's the other thing, is like, you know, we don't want to hurt people's feelings. We want to be really sensitive, but at the same time, I think it's helpful to be direct, because sometimes people do know that they have that it's bigger than what they're telling you they think it is. You know, they're minimizing it. And so I've found that sometimes just coming out and saying, I think this is either disordered eating or even a little bit more serious than that. You know, I think I want to know what your opinion is on that. A lot of times it'll, you know, people are able to identify where they're at, and at least you'll know.
Right. The one thing I really love is that you just are putting forth is you're spending time with your patient to really get to know and to really ask specific, you know, ask questions that are going to elicit good responses for you then to be able to build their treatment, as opposed to sometimes in behavioral health, what we find that time spend is not there in other diagnoses. This sounds like an amazing model for for uh,
Well,
for
I
other
mean,
things as well.
I'm fortunate, right? Because I'm able to spend 60 minutes or 30 minutes with
Mhm.
people who have the finances to see me, pretty frequently. But I rely so heavily on the eating disorder therapists that are skilled and the registered dietitians to do a lot of the work, because they're the ones that I call and say, I need you to do an assessment for me and call me afterwards and tell me what you think, because this is what I'm seeing and I'm concerned, and I'll do the labs. But I need you to ask them about all those behaviors in detail and let me know, are we in trouble or not? Because I couldn't possibly do it alone without a team. I mean, between lab work and me not being a dietitian who actually knows exactly how much people need to get in, I'm just looking at all the behaviors. They have to do that piece. I can do some of the behavior piece.
But yet again, another great point, the collaboration with
Yeah.
others. And if it was a pharmacologist, you had to go to the pharmacy, because if that was a big component of treatment, that you'd have that whole treatment team and those resources in play at the onset. Um, so I guess I know we have some questions for some of the clinicians on the line asked, and maybe we'll have a minute or two to get there. Well, maybe not, but maybe we'll end with two things.
Okay.
Um, One, um, what is your approach that you recommend for food and body image related concerns?
So, health at every size, which is, I'll read it specifically to you what the principles are: accepts and respects body shape and size diversity, eating in a flexible manner, valuing pleasure, but honoring internal hunger cues, and finding the joy of one's movement in a way that makes someone feel physically vital. So, body movement for pleasure. That's the approach that when I'm trying to find providers that are going to be on the same page as me, where I'm looking for somebody who's familiar with health at every size. And interestingly, patients know this. People who have had some treatment, they'll come in and say, I don't want you to weigh me. I am taking the approach of health at every size. Weight doesn't define who I am. And I want to have this conversation with you about who I am. It's really cool to see that.
That's amazing. I love that. Maybe we could get that and put that up on the end with the resources, because I think that is maybe something we should all live by.
Right. I mean, I'm telling
You
you,
know, I mean,
it was like, it opened a whole world to me, being able to work in that center and being able to learn from my patients who went to, some of them 2-3 years of treatment before they make it home. Just very prolonged treatment. Those are, the cases that have a lot more healing to do, right, from trauma and things like that. But it's amazing what I've found, what I've learned from them about how to heal. It starts even just as simple as your food. It's not like, oh, it's your gut health. I mean, we're talking about like actually treating your body, the way that, you love it. You learn to love it.
yeah, it's the only one we've got. Yeah, why not treat it like the temple, right? Our own personal temple. And if we could, Jess, if you're listening, I'd love to put up the resource list for you all to see, because Mary obviously referenced a few of those. And for some of the, we have, I think, a minute or two, Mary, if there was any other questions that you pulled from that you think uh, might be of benefit. Um,
Well,
and
I actually, if you're okay, I wanted to just like touch on the resource page,
yeah,
kind of tell everybody where, a little bit about it. So I follow a couple people that are just total BAD ASS yeses. And those are the Instagrams that I put up there. I mean, they are like trailblazers. 2 of them are writing a book together. They are phenomenal. Jennifer Rollin and Colleen Reichman. They've just done phenomenal work. And then Jennifer Rollin opened the Eating Disorder Center, which is outpatient. So recovery coaching, I didn't touch on that, but because of the restrictions based on state, you can get a recovery coach out of state. So these are people with experience of treating eating disorders. So you can have a coach instead of a licensed therapist, but typically these people are vetted. And so, you know, a good coach is amazing. Put some downloadable resources of free ebooks that talk about the non-diet, which is awesome. It's all the stuff I touched on, but even in more detail, even some of the stuff in there for little kids, since, you know, a huge percentage of our little kids are worried about what they look like and how much weight they're gaining. And then some online support groups, you know, I put those in there where if, you know, there's one that's just if you're contemplating if you have an eating disorder, and it starts leading people to explore some treatment. You know, they don't have to commit to anything, they can just show up. And then for the professionals, since there were so many, I put some resources. I signed up for a lot of the eating disorder centers have free continuing education that they'll send you emails every month and you can do them. And it's registered dietitians and licensed therapists who are certified, and you know, they just send them to your email and you register, and they love to educate people because they don't have anyone to send people outpatient to, unless we know what we're doing. And then very lastly, the findedhelp.com, that is a place where you can go in and put your zip code, and whether you're looking for a higher level of care or just, you know, an outpatient provider, and it'll tell everyone closest to you. So I tried to compile what I thought was not just going to be like a 1-800 number you're calling, but like actually real people and places and things and people doing things that you can get a hold of. You know,
that's amazing. I love that for treatment centers, you know, that it's the ones that is terrific, because we don't have anything very locally, do we, Mary?
We have one registered eating disorder dietitian locally, just one in Hampton Roads, and she is completely booked. And one eating disorder therapist that I know of who has the special certifications in Hampton Roads, and she's very full as well. So I do actually have to find resources for people all over the US if I can. And there's scholarships too. I mean, there are scholarships for people who can't afford treatment that need to get in. They do some of these treatment programs do scholarships to help people get in.
And I actually know of someone who, for their daughter, their adult daughter, did get a scholarship so she could receive treatment, and today is living a very full and happy life because she is definitely in that recovery piece. But it was all thanks to the intensive treatment she was able to get. So we thank you so much, Mary, for your time. I thought this was amazing. I learned a ton. And I think I'm sure everyone else did. We would like to just say your support, and it's not just here that Mary is supportive of what we do with NAMI. She's been a partner of ours for quite a bit now and has become even a facilitator for one of our programs. So you're great, and thank you.
Thank you.
And make sure this will be posted on YouTube. You can find it on our website. It'll be housed there. So please, if these are good programming, which I think everyone will agree they are, we'll just keep doing these and bringing these different topics.
Oh yeah, and for everybody who's a professional that wants to watch Dr. Spiegel next time, he's my mentor, not for the eating disorder piece, but for everything else, like my life and my professional career. He's amazing, and he's a professor at the medical school. He's brilliant. So if you get a chance to sign up for that one, you won't regret it. No. He's great.
Yeah, and he's definitely an entertainer.
Yeah,
really smart entertainer. So thank you guys, everyone, for coming. And if there's anything you need, don't hesitate. NAMI, Coastal Virginia, and then you have our phone number. You know, call, because we're here for you. Thank you guys. We appreciate you.